Welcome, everybody, to today's live from Cleveland Clinic broadcast. I am Matt Crow from Cleveland Clinic, Cleveland, Ohio. It's a pleasure to have you join us tonight for another exciting and maybe the most exciting session, What's New in Gastroesophageal Reflux Therapies. This is going to be a great opportunity for nearly 1,300 healthcare providers from around the world who have registered from more than 100 countries. Canvassing the globe and from all of the continents. And immense thanks to our supporters for this educational activity, Cook Medical, Janssen Biotech, Medtronic, and Olympus Corporation to make this educational event happen, and their ongoing support for the Cleveland Clinic Live series. It's really my distinct pleasure as the activity director to introduce the faculty for tonight, who are among the most esteemed physicians, not only on this campus, but in their fields around the world. And we've tried to make this a very diverse panel to look at medical, endoscopic, and surgical therapies and really be on the cutting edge of what we're going to do. And I'm immensely grateful to have Dr. Scott Gabbard from the Department of Gastroenterology, Dr. Ricard Corsellis from the Department of General Surgery, Dr. Chelsea Fang from the Department of General Surgery, Dr. Yi Chen from the Department of Gastroenterology, and Dr. Roberto Simmons-Linares from the Department of Gastroenterology lecture tonight. I'll give more introductions when we have their specific talks, but we hope this is an interactive session. Obviously, there's a lot to cover in the next hour and 15 minutes, and our experts could all speak on their topics for that long, I'm sure, and we'd be grateful to hear these lectures. But please put your questions in the chat. Hopefully we'll leave some time, and our speakers will be sure to stay within their time constraints so that we can ask a question or two after each talk. And we really look forward to the presentations tonight. Thanks all for your participation. So again, to our attendees, go ahead and put questions in the chat, and then I will ask our presenters at the end of their presentations. Great. So to start, our first speaker is Dr. Scott Gabbard, who is staff in the Division of Neurogastroenterology and Motility Center. And he's an assistant professor of medicine in the Cleveland Clinic Learner College of Medicine. And Scott's going to be talking on functional heartburn diagnosis and treatments. Welcome, Scott.
Thank you so much, Dr. Crow. It's a pleasure to be here. I've known Dr. Crow since both of us had no gray hair. So I know there's a lot of amazing, sexy talks on new therapies, new surgeries, and I'm going to talk to you about the least sexy thing, which is functional heart reflux. Because we all see patients in our clinic who are like this patient. In fact, I just saw one yesterday. Very similar story. A 45-year-old who presents with constant heartburn, constant globus, cough, dyspepsia, fullness, bloating, with all meals. Symptoms persist throughout the day. No improvement despite PPIs twice a day. I think even providers have put her on 3 or 4 times a day PPIs, H2 blockers, Carafate, really no improvement or minimal improvement. And the patient comes to you, be it you're a gastroenterologist, a surgeon, an internist, begging for surgery. Doc, you're my last hope. You need to do surgery and fix me. The patient's had 4 previous EGDs over the past 10 years. And this was the most recent EGD. Again, this is a completely normal Z-line, no hiatal hernia. So I tell our fellows, there seems to be, in today's day and age, what I call a reflux reflex, where providers, for whatever reason, have a reflexive thought that anyone who has burning is labeled as being refractory GERD and must go to surgery. And I'm hoping that in the next 10 minutes, I can convince you, don't go down the reflex pathway. Take a step back and ask yourself, is this truly reflux? So this 45-year-old constant burning with that EGD, failed PPIs, what's the next best step in management? Should we do an esophageal manometry? Should we do pH testing on PPI? Should we do pH testing off PPI? Or should we refer her to Dr. Crow for a fundoplication? He's a fantastic surgeon, and I'm sure would do an amazing job technically with a fundoplication. And I'll argue that the answer really should be pH testing off PPI. So if you have a patient who has symptoms not responding to PPI and a normal EGD, obviously we all know, do the pH testing and do it off of PPI. Right? So GERD testing. The number one thing is you really want to determine, does the patient have objective evidence of GERD or not? And in GI, really what we consider the objective evidence is erosive esophagitis, not grade A can be physiologic. So I'm thinking grade B or higher. Now, a short segment Barrett's, a variable Z line, 1 centimeter of salmon colored mucosa, that is not objective evidence of reflux. When we talk about Barrett's, really it's 3 centimeters or more would be considered objective evidence, or abnormal pH testing off of PPI. Not objective evidence would be symptoms. Symptoms are completely not objective. Grade A erosions, a variable Z line, or reflux on a barium esophagram where they turn the patient upside down and shake them and the barium comes up a little bit. That's not objective evidence of reflux. Now, when a gastroenterologist does pH testing, really what we care about most, with all due respect to Dr. DeMeester, we care most about acid exposure time. DeMeester score, no gastroenterologist really is going to focus on DeMeester score. That's just a yes or no variable. I want to know, what is the acid exposure time? And really, depending on the lab, our lab for a long time thought normal was less than 5.5% of the total time. Really, less than 4% is completely normal, no questions. 4 to 6% is considered a gray zone. Greater than 6% of the total time with acid in the esophagus is currently considered abnormal. Though I will tell you, there are some experts in the field who have repeated pH tests in normal individuals and found that that number may actually be low. And in 2020, in the 2020s, where a lot of people have more reflux, we may actually need to start considering having a higher threshold. But that said, really 4 to 6% considered a gray zone, less than 4% pH acid exposure time, that's considered normal. And I would argue that anyone doing pH testing, please look at the please look at the pH test. Please look at the tracing. I'll tell you why in just a sec. Here's a patient, pretty normal level of acid exposure. They had a meal right here, a little bit of acid with a meal, but otherwise really no reflux on this pH test. Here's a patient really interested in blue bar, only in the supine position. This is actually a patient with scleroderma, no peristalsis. They lay flat, a lot of reflux. They don't have peristalsis to clear it, so they get a really long episode at night. Here's a patient who has about the worst reflux I've ever seen. This is a patient with scleroderma who had a lung transplant, and the acid exposure time was around 75%. The DeMeester score was somewhere in the 300s. This patient actually got a lung transplant and is still doing pretty well. This, though, is why you should look at the pH tracing. You can see here the patient has a little bit of reflux, a really prolonged event, and then all of a sudden, no reflux, way high levels, or way high pH, way low levels of acid. This is actually the capsule falling off, the Bravo probe falling off. You can see a little bit of reflux, falls off, it's in the stomach for a few hours, and then empties the stomach, and there's no acid after it empties the stomach into the intestines. This is a patient who actually needs the test repeated with maybe a catheter-based test. So this is why you should always look at those tests. Symptom association, so we have the patient hit the button, and they'll tell us, hey, I had burning. They'll hit the button, and anything greater than 50% is considered considered positive. So they hit the button 10 times, there's 10 that's symptom association. They hit the button 100 times and there's one episode of heartburn, that is poor symptom association. So I use greater than 50% being positive. So back to the case, 45-year-old, constant heartburn, pH testing off PPI. She really says she doesn't feel any worse off PPI. And her total pH time less than 4 is 0.5%. So she's completely normal. She hit the button for heartburn 156 times. By chance, 3 were reflux, 153 were not. Now, when you get this patient, don't just show them the door and say, we don't know what you have. I'm sorry. If you guys are all treating GERD, please make a formal diagnosis. This patient has normal acid exposure, poor symptom association. This is functional heartburn. And you don't say this is, we don't know what you have. You say this is functional heartburn. This is a nerve problem. You can see here, patients who have erosive esophagitis, non-erosive disease, acid is causing their symptoms. Patients who have normal pH testing, very little acid, their problem is nerve issues, esophageal hypersensitivity. So the patients with normal appearing esophagus really think that it may be a nerve problem. And in fact, when they've looked at patients who don't respond to PPI, 3/4 are functional. 3/4 are either functional heartburn or reflux hypersensitivity when they have normal levels of acid, but they hit the button whenever they have acid. That's hypersensitivity. So stop the reflex. Patients who don't respond to PPIs are likely to be functional. And again, the minority, only 1/4 of them truly have persistent GERD. And this is from our paper that looks at or that describes the pathophysiologic basis for functional heartburn. And essentially what I tell people, you get some sort of immune-mediated event, be it a stomach bug, a virus, pathogen, allergen, your immune system reacts, right? So you get stomach flu, white blood cells, so eosinophils, mast cells, lymphocytes get activated. They fight off whatever the acute event is, but in about 10% of the population, the downstream effect of this activation, IL-4, 5, 13, among many others, I'm sure, the downstream cascade of this is it causes nerve pain. Similar to patients who go to Mexico, you get sick, you come back and you have IBS. Well, the same thing can happen in the esophagus and you can get functional heartburn, and it's essentially nerve pain in the esophagus. So the definition is burning retrosternal discomfort for at least 3 of the past 6 months. Patients have normal pH tests, poor correlation with reflux events. Those patients don't have GERD. They have functional heartburn, okay? Again, I don't need to tell you, PPIs, they don't really respond to that. That's why they're seeing you. So try to get them to the lowest dose or take them off PPIs. The mainstay of treatment for this is neuromodulators, and there's very little research in this topic, but neuromodulators that have been used, certainly SSRIs like citalopram or escitalopram have been described, and my favorite neuromodulators, low-dose TCAs like amitriptyline at 10 milligrams, increase it by 10 milligrams every 2 weeks. Very, very effective for functional heartburn. We actually have a study right now looking at transcutaneous electroacupuncture. So that may be something in the future patients can do at home. Just a little electrodes at acupuncture sites, giving electrostimulation may have some benefit. And then I wish we had more of this available, but behavioral therapy, hypnotherapy has been described with response rates up to 90%. So certainly some would argue, and I would argue, that for any functional esophageal disorder, behavioral therapy would probably be first-line therapy, depending on cost and availability to the patient. So the main points: stop the reflex, right? Patients with normal endoscopy think about functional esophageal disorders, right? If they have a normal EGD, perform the pH testing off the PPI, okay? There's no reflux on the testing, stop their PPIs, and really think about behavioral therapy or neuromodulators for patients with functional heartburn. And lastly, do not perform surgery on patients with functional esophageal disorders. I know no one here does, but again, normal testing, don't just show them the door, don't do surgery on them, give them them a diagnosis. You have functional heartburn, and either treat or send them to a center who can treat, your gastroenterologist, but give these patients a diagnosis. With that, I will stop.
Excellent talk, Scott. Very provocative. I'm going to put in the chat, stop the reflex. It's kind of a mouthful to get out, but I think that'll stick to everybody here. There's a question from Craig Morgenthal. What are your thoughts about, for example, 30 minutes at the start of pH recording? Should that be reflux at the initial 30 minutes? Should that be disregarded? And can that acid exposure time be removed from the time score calculation?
Yeah, I mean, that's a really good question. And again, this goes to like looking at your tracing. If say, you did the test and say you placed the wireless probe under sedation and, the only time the patient had reflux was during that initial 1 hour after getting sedation, ask yourself, is this a true test of, is this a true representation of the patient? And then that's where you also look at the rest of the study. If the patient, aside from that 1 hour, was hitting the button 100 times for heartburn, and there's no reflux after that first hour, I'd consider cutting that out, right? Because that patient probably has functional heartburn. And the last thing you want to do is get them a surgery like a fundoplication, because guess what? You take away their fundus, what are they going to complain of? They're going to get functional dyspepsia, right? Fundus opens up and expands when you eat a meal, and you do a fundoplication, you take it away, you impair fundic accommodation. You're just going to give this patient who gets functional GI disorders a new functional problem, functional dyspepsia, to go along with the functional heartburn that you didn't fix. So, that's where I say really look at the tracing, look at the patient. It's not just a simple, hey, the Demeester score is 15.0, normal's less than 14.9. Aha, I figured it out. You need surgery. Like, look at the whole tracing, look at the patient.
Excellent. Scott, you're getting a deluge of questions in the chat here. So great talk. You have 30 seconds to answer this so we can get on to our next speaker. Do patients have both GERD and functional heartburn together? Is that possible?
Absolutely, you can have overlap.
And what percent? Is that a rare thing or is it relatively common?
No, I mean, no one's really documented what percentage of patients with true GERD also have functional overlap. So there certainly can be functional overlap. The patient can have mild reflux, right? Normal EGD, but an acid exposure time of 7% with partial response to PPI. And they still have burning despite being on PPI. That's when I'll say, hey, you only have mild reflux. I'm really concerned about something like surgery, and I'll add neuromodulator or, again, behavioral therapy to those patients. Try to save them from undergoing a surgery for, what appears to be a mild esophageal acid exposure. So 100% you can have overlap.
All right, so clearly the next Cleveland Clinic Live needs to be functional heartburn. We'll do an hour and 15 minutes on it. With that, we're going to move on to our next speaker, Dr. Yi Chen. She's in the staff in the Department of Gastroenterology here and assistant professor of medicine, and she's going to be speaking on new medical therapies, potassium channel blockers in 2024. Dr. Chen, looking forward to your talk. Thank you.
Thank you so much for that introduction, Dr. Crow, and thank you for the opportunity to participate in this forum. All right, so I'm a gastroenterologist. I'm going to talk about medical therapies for acid reflux. And specifically, we're going to focus on potassium competitive channel acid blockers. All right, so here's an outline of my talk today. We'll start with a case presentation. We'll talk about pharmacodynamics of PCABs and talk about some clinical trials of vonaprazan. So in this case, you have a 53-year-old man who complains of odynophagia and dysphagia to solids. He describes heartburn, he has acidic regurgitation, it's worse after meals and when supine, and improves with Tums. His past medical history is significant for osteoarthritis, asthma, and obstructive sleep apnea. The medications that he takes include Celebrex, albuterol, ipratropium, and ibuprofen every day. He has had no previous surgeries, And his social history is significant for him being a mechanic, always lifting more than 50 pounds at work. He never smokes. He drinks 2 beers a day and constantly drinks pop. His height is 183 centimeters and weight is 230 pounds. So in this gentleman, we decided to do an upper endoscopy before starting medications. And this is what it looks like. So you can notice quite a difference from the case that Dr. Gabbard presented, that there is grade C reflux esophagitis. And this patient was started on omeprazole 40 milligrams twice a day. Now in 2 months, you see him back. You ask him about how he's doing on the omeprazole 40 milligrams twice a day. And he says, oh, I don't feel any different. I feel even worse. So then do you start thinking about whether this patient could have functional heartburn or refractory GERD, right? So you do an upper endoscopy, and this really jumps out at you. So this is not functional heartburn. This is refractory GERD. So he still has persistent grade C reflux esophagitis. So what would you do next? So this patient went on to have a pH impedance study on omeprazole 40 milligrams twice a day, just in case you didn't believe that that was refractory reflux. That showed the acid exposure time was 2.5%, reflux episode 61, and the mean nocturnal baseline impedance was low at 1.94. You can see that these numbers are a little bit different from the normals that Dr. Gabbard presented for patients off PPI therapy, because this is done on PPI therapy. So these numbers are actually consistent with reflux. The normal acid exposure time for someone who's on omeprazole 40 milligrams twice a day should be less than 1%. And he went on to have a high-resolution esophageal manometry that was thankfully normal. So what would you do next? Should we refer him to Dr. Crow's team for repair of a 2-centimeter hiatal hernia? So then the patient asks you about the side effects of fundoplication. And one of the first things I told him was that, well, you're going to have to stop the soda. And he said, well, can we do something medically? So medically, we put the patient on vonaprazan, this new kid on the block, 20 milligrams once a day. In 2 months, his upper endoscopy showed some healing, but still grade C reflux esophagitis. Then he asked you, what else can you do? Well, we went up to twice a day. And this is his upper endoscopy. So just to jog your memory, this is on omeprazole 40 milligrams twice a day, and this is on vonaprazan 20 milligrams twice a day. The difference is PPI versus a PCAB. So what's different about PCABs? They're actually essentially proton pump inhibitors as well. So they both work on the proton pump. What's different from PPIs are the pharmacodynamics. So here's a really great figure from American Journal of Gastro from 2022 about how the medications work differently. So this is a diagram of a parietal cell in the stomach. So you have the luminal side, so the acid side, and the cellular side over here. So these structures are the proton pumps. The blue pumps are the activated proton pumps, and the gray pumps are the inactive proton pumps. You can see that PPIs work by stopping the potassium and hydrogen ion exchange and stopping the acid secretion. But PPIs need to be activated in acid, and that is critical. PPIs need a little bit of acid for activation. PPIs only work on activated proton pumps, so they don't work on these inactivated proton pumps. So that's how PPIs work. Now, switching over to PCABs. So PCABs can bind to both inactivated and activated proton pumps. They're not pH dependent. They don't require acid for activation. And PCABs bind to the proton pumps via an ionic bond that's reversible compared to the covalent bonds that PPIs bind to the proton pumps with. So the shortcomings of PPIs, can the PCABs fill the void? So summarizing that figure that we just looked at, PPIs are Oh, PPIs are actually degraded in acid. They're not stable in acid, but PCABs are stable in acid. PPIs require enteric coating, and that leads to delayed onset, but PCABs don't need enteric coating, and they can lead to rapid onset. The PPIs are degraded quickly in acid, so that leads to their short half-life of 1 to 2 hours versus the longer half-life of 7 to 9 hours for PCABs like vonoprazan. PPIs only bind to active proton pumps, whereas PCABs can bind to both inactive and active proton pumps. Just like the last picture, PPIs require acid for activation. So that means that the patients have to take their PPIs 30 minutes to 60 minutes before a meal. Whereas PCABs do not require acid for activation, so they can take it at any time. And finally, PPIs are metabolized mostly through the CYP2C19 system, and that leads to a lot of genetic variabilities in metabolism. There are these ultra-rapid metabolizers of PPIs that have poor response to PPIs. And of course, through this enzyme are a lot of other drugs. So drug-drug interactions are common and commonly limiting use of PPI medications. But that shortcoming is also overcome by PCABs. So on paper, vonoprazan sounds really good. It sounds to fill all those deficiencies of PPIs. How do they do clinically, though? So this is a landmark paper published in Gastro in 2023. That was a randomized controlled trial looking at vonoprazan versus lansoprazole for the healing and maintenance of erosive esophagitis. So in this study, they included patients who had LA grades A through D esophagitis, and they had about 1,000 patients. They randomized them to receive vonoprazan 20 milligrams once a day versus lansoprazole 30 milligrams once a day. In 8 weeks after the drug therapy, these patients underwent an EGD. Now, the vonoprazan 20 milligrams once a day group had 93% healing of their esophagitis versus 85% healing for the lansoprazole group. The biggest difference, however, was seen in the patients with the more severe type of esophagitis, specifically LA grades C and D. Then the study went on to the maintenance phase. So the patients who achieved healing were then re-randomized to vonoprazan 20, vonoprazan 10, or lansoprazole 15. After 24 weeks of maintenance therapy, these patients were scoped again, and they found that vonoprazan 20 milligrams was able to maintain healing in 80% of patients. Vonoprazan 10 milligrams maintained healing in 80% of patients, and lansoprazole 15 milligrams maintained healing in 72% of all patients. When divided by, or when doing the subgroup analysis for the more severe type, you're seeing more of a difference for the more severe type of esophagitis as well. So this study concluded that vonoprazan was non-inferior and superior to lansoprazole for the healing and maintenance of erosive esophagitis. Then how does vonoprazan do in the non-erosive disease? That's the patients who may have functional heartburn. So the same group went on to do a placebo-controlled, randomized controlled trial. They took about 700 patients who had negative EGD, so EGDs that were negative for grades A through D esophagitis. They randomized them to placebo, vonoprazan low dose, and vonoprazan 20 milligrams. And then in the first phase of the study for 4 weeks, they looked at their symptoms. So by symptoms, they calculated this thing called 24-hour heartburn-free days, and that's the percentage of 24-hour heartburn-free days. So on placebo, about 30% of patients achieved 24-hour heartburn-free days. On vonoprazan 10 milligrams, about 45% achieved that. And vonoprazan 20 milligrams, also 45% achieved 24-hour heartburn-free days. The what's important to point out is that with just one dose of vonoprazan, you start seeing the separation and the difference from the placebo group. And also, the study demonstrated that there's really not much of a dose-dependent difference. So the low dose of vonoprazan would be sufficient. Then they took these patients and went on to an extension period where the placebo group was re-randomized to vonoprazan 10 milligrams versus 20 milligrams, and the vonoprazan groups stayed on the same dose. And again, the placebo group, as soon as they got the vonoprazan, their symptoms did improve. Now, it's notable to report from this study that none of these patients had pH testing prior to enrollment, so we don't know if they actually had reflux or if they had functional heartburn. So it's possible that many of the patients that didn't respond to the medication may have had functional heartburn. And Dr. Crow, do we have time to talk about the H. pylori study?
I think if you can make it very quickly, we're we're at
Okay.
time for you.
All right, so the gist of this study is vonoprazan leads to improved control of gastric pH and leads to improved susceptibility of antibiotics, which can overcome antibiotic resistance. So even vonoprazan dual therapy has been found to treat H. pylori really well in patients who are who have clarithromycin resistant strains of H. pylori. Okay. And then there's some other PCABs that are potentially coming down the road. All right, so take-home points. I would consider PCABs or potassium channel acid blockers in patients who have erosive GERD, who have not a complete response to PPI medications, but maybe some response, who are unable to do preprandial dosing or have gastroparesis. In our patient, he actually was taking his omeprazole after meals and at bedtime, so that's probably why it wasn't working. And of course, to consider vonoprazan or PCABs in the treatment of H. pylori and drug interactions. And with that, that's my last slide.
Outstanding presentation. Such a fascinating topic, and I think will impact all our practices in the future. I asked the attendees to put questions in the chat here, and if you can just answer some of those if you get a chance. But I do have one really quick question for you. Because it doesn't need acid to activate, is this the ideal medication for patients after gastric bypass who have low acid, but reflux and maybe anastomotic ulcers? Is that what we should be using now?
That would be a great potential for this medication, but I don't think it's been studied yet.
Okay, there's an opportunity for somebody to answer a question. Outstanding talk. Thank you so much. We'll move on to our next speaker now, Dr. Roberto Simmons-Linares, who's the Director of Bariatric Endoscopy here at Cleveland Clinic in the Department of Gastroenterology. And he's going to be speaking on endoscopic therapies for GERD, ready for prime time or still works in progress. Again, ask your questions in the chat. Make this provocative. We're going to push Dr. Simmons-Linares on some of the data he's going to show us. Roberto, the floor is yours. Thank you.
Thank you, Matt. Pleasure to be here with such an outstanding panel. Okay, guys, so we're going to talk about endoscopic options to manage GERD. And congratulations to the other two speakers, Dr. Gabbard, Dr. Chin, really, really great and insightful talks. So TIF has been around the transoral incisionless fundoplication for a while now, around 16 years, and there has been multiple devices in the market, multiple devices study, multiple versions of the procedure, and multiple techniques, and that continues to evolve. So what is TIF? To really go directly to the point, it's an endoscopic procedure to do a fundoplication. And, you know, we know that medications are really, really good. Approximately 80% of people will, have good control of GERD and its complications with medication, especially PCABs that I'm actually using in my practice now for almost a year now since they got approved for H. pylori and now for GERD, for erosive and non-erosive esophagitis recently, well, a few months ago. So because of that, obviously, you may think that there is maybe a small amount of patients that will require procedures or surgery. But actually, since GERD is so prevalent, we have so many patients with it, we may have a big, actually a big number of patients that need other treatments, such as TIF or surgical fund application. So TIF, it is basically an endoscopic, non-laparoscopic or non-surgical procedure that will actually provide a serosa to serosa plications. Basically, it's an esophagogastric plication. And one of the main issues, and Dr. Crow is actually an expert in this field. He has plenty of experience with endoscopic TEF fund application and surgical fund application, among other foregut surgeries. So you may remember that in the past, the devices problem was we could not get a good esophagogastric plication. Couldn't pull the esophagus down, reduce the small hernias. And that was a problem because then you end up with a gastrogastric plication. And if you could not, pull the esophagus down a little more, then you end up with, that persistent small hernia, which also will impact your outcomes of treating GERD. So now, with ESOFIX device, which is the most studied device, we can actually do an esophagogastric plication, and we can also do a wrap. And the data has the wraps at 270 degrees, but now what we're doing, because the technique, remember I told you it's been evolving over the last few years and decade actually. Now we aim for about a 300 degrees valve and wrap. So there's a paper I'm going to show you that is a multi-center study that shows that 300-degree wrap and data of that. So, is this procedure effective? Yes, I'll show you some data, obviously, with the interest of time, but it is effective. It is pretty safe. Usually the side effects adverse events are less than 2% in even older data, but now we know that it's around 1% or lower, which makes it really attractive. So medications are very, very, very effective, especially if you go over the different differences among PPIs, the newer generation PPIs, and especially the newer medications such as PCABs. We know that this medication is very good, but if you have some partial response to it, or patients are having a hard time to take these medications, or for whatever reason they cannot be on these medications for long term, or don't want a surgical fund application, or don't want to take the PPIs for the next 40, 50 years, and they want to see if there's another option. Well, TIF is a good option. Usually you want to do this in patients that don't have obesity, but if there's no contraindication to do this in patients with mild or class 1 obesity, but best scenario is if they don't have obesity. If they do have obesity, then you have other surgical options such as gastric bypass, or what we've been doing here at Cleveland Clinic, we do a TIF plus an endoscopic sleeve in the same session, and I'll show you a little bit about that. Now, what are the, in a nutshell, what are the inclusion criteria for this endoscopic fund application? So, well, you have to have symptomatic GERD and confirmed GERD, and Dr. Gabar went over that. So you have to have true confirmed diagnosis of GERD. You want to see that acid exposure. You want to have a pH testing. You could also have other, questionnaires. If you see the data, you could also use obviously your clinical judgment to see when does this GERD happens or not. There are other interventions that you may have to do before jumping into a TIF procedure, such as if it's nocturnal GERD, for example, medications such as PCABs will work better usually because of what Dr. Ching already explained us, but also other interventions such as a special anti-GERD pillow, etc. So all those things you have to optimize other things such as like smoking and other risk factors. But then as an endoscopist or surgeon, what do we need to look to be considered for TIF? You have to have a heel grade, hernia heel grade less than 3, which is heel grades 1 and 2, in an actual hiatal hernia less than 2 centimeters. So the heel grade is used to classify the valve, the opening of the valve in retroflexion during endoscopy. So heel grades 1 and 2 will qualify for TIF, and hernias less than 2 centimeters. Now, exclusion criteria, basically, if you have a large hernia, more than 2 centimeters, if you have a more advanced heel grade, like 3 or 4, if you have severe obesity, if you have severe esophagitis, erosive esophagitis like C and D, also you should not be doing a TIF. I've had a couple of times when the patient comes in and there is severe inflammation, I have to treat that first before we can actually do the plications due to a risk of more leak and healing, etc. Severe strictures, achalasia, other motility diseases of the esophagus are also a contraindication, and obviously portal hypertension due to varices, bleeding, as well as immunosuppressed patients, and pregnancy as well, due to avoid an elective procedure during pregnancy. Now, before TIF, you will actually diagnose GERD. You're gonna, at Cleveland Clinic, we will administer a quality of life questionnaire to make sure we also track those symptoms well. And we will make sure that the patient has manometry. I also do an esophagram and a pH or Bravo testing, as well as an endoscopy to make sure that you have an assessment of the hernia and the heel grade. In our team here at Cleveland Clinic, we also have the patient see a dietitian, a psychologist, and obviously an esophagologist specialist such as Dr. Ching, Dr. Gaber, as well as endoscopists. Me or Dr. Crow can see these patients for the actual procedure. Now, obviously, the positive follow-up, we're going to follow up clinically. If there is any indications to do another pH study, you could do it clinically. But if you're doing research, it will be ideal to check the acid exposure post-TIF. But we'll show you the data. Most studies don't have this acid exposure, which is a problem, but newer data does have this acid exposure data. Now, the device looks like what you have on the screen. It's like a bigger scope where you put a baby scope through it, and then you are able to retroflex the device. It has outside, it has multiple, it has a wheel, and it has like a helix catheter, and it has actually the plication loading device and cartridge. So what you end up doing is you end up retroflexing the device and the scope through this area, and then you pull the esophagus down and do an esophagogastric plication. When I say pull, you actually grab it with this little helix, which is a corkscrew metal sharp device that is able to get into the tissue, usually submucosa or muscularis, and then you can pull the tissue to actually plicate and also wrap the tissue. And like I was saying, most of the data I'm going to show you is from the TIF 2.0, that is at least a 3 centimeter valve. We usually aim for 4 or 5 centimeter length of the valve, and also at least at 270 degrees. But lately we're doing 300 degrees to try to wrap it a little more, because there's really the risk of dysphagia or strictures is so low that now the procedure and the proceduralists are being a little more aggressive in terms of tightening this and creating this new valve. Now, this is kind of the concept of how you deploy this plication, these purple plications. I'll show you a quick video in a second. But before, this is one of the patients I did, 51, some hypertension, GERD, well diagnosed by one of my colleagues in the swallowing center, responded to PPI, but there was kind of like a refractory symptoms, and the patient has tried multiple medications, PPI medications. So was referred to us for consideration of a TIF. We did an endoscopy. All the workup confirmed basically the inclusion criteria for this patient. There was a small hernia, and then the patient didn't want any surgical fundoplication. Also, many times, patients will elect this because if this could, and I'll let my surgical colleagues talk about this, but if the TIF fundoplication, is loose after 5-7 years, and then can the patient get a surgical fundoplication? Yes, that's possible. So it doesn't really burn any bridges, but obviously you have to do this with the indications I mentioned. So we did the TIF, and this is how it looks in retroflexion. So that's the scope through the device. And then basically you are retroflexing. This is the actual placement to give you an idea. The device is straight, and then we're gonna actually retroflex the actual device. So we're gonna forward a little bit, and this is actually the device retroflex, as you can see, and the helix we're grabbing right at the Z line, we're grabbing the tissue down, and you basically grab the tissue to make to wrap, and then we usually start on the screen around 11 o'clock, and then we go back to 1 o'clock, as you can see in this video. And then you keep on basically working on that fund application. It takes about 30 minutes to do the procedure, plus your, diagnostic endoscopy, plus you're looking at probably 30 to 45 minutes to do this procedure. So it's not a very complex device. The device is pretty automated to deploy these applications once you are in a good position. And like you see in the video now, I'm wrapping all the way pretty aggressively to get that 300 degrees wrap, making sure that you're not grabbing any other organs, such as the diaphragm, and making sure that you're pulling the esophagus down and you're not grabbing other off. And you can see like the fundus is open, and then we're ready to deploy. And we keep on working on that. You could see a little mild bleeding is normal. It will stop. It's mucosal bleeding, but bleeding can happen in less than 1%. And then if we keep on working on this, you will finish this is basically to show you how does it look after you finish. This is from the forward view. I don't know what happened with the retroflex view. And from the esophagus, you could see the actual, I don't know why it's not showing the valve, but you could see that the tags are in the actual esophagus and in the stomach. Case 2, this is an interesting thing that we started doing recently. Basically, the patient...
Roberto, we're a little behind on time, so maybe you can fast forward through this. Thanks.
Yep. We did an endoscopic sleeve and a TIF in this patient that was eligible, and I just trying to show you the upper GI series. You could see that the stomach is pretty narrow from the ESG, and then we did a TIF. There was no leak, and we discharged the patient. Anyways, now I'm going to show you 3 key studies. This is an earlier study that actually shows that, it's a meta-analysis, and they included 3 randomized trials. The actual reflux episodes actually decreased with TEF, but the acid exposure did not, which is, something that we want to see. Long term, you could see that the efficacy of the TIF, if you only measure the symptoms and use of PPI, it decreases over time from the peak about 70%, it goes down to 40%. And then in terms of cessation of PPI in this meta-analysis, there is a nice, about 40–50% of cessation of PPI in this meta-analysis. And there's a different meta-analysis from Professor Thompson that shows that it's up to 70% that people can decrease or discontinue the PPIs. This is a new study led by Barham Abudai and Ken Chang, who are experts in TEF. And you could see that in this multi-center study, they had about 100 patients, 85 patients, and the clinical success was pretty high, 94%. The quality of life improved almost 90%, but also the acid exposure, was normal in 72% of patients, which is really good. This is what we want to see, so that we tell patients now that about 6 to 7% of the time, you're going to have that acid exposure improve. And the last meta-analysis I want to show you is published in Gastro, in our journal in Gastroenterology, by Joel Richter. And it shows, and they're compared lap Nissen fund application with TEF with PPI. And obviously, we know that the surgical fund application is very effective and durable. And it was the best to actually show this improved pH or acid exposure. Like you can see here, TEF, PPI, and Nissen. And Nissen takes the lead. But also, TIF does work for this. And, again, the data that was included is old data and newer data. So we have to be careful when we read this data. Now, in conclusion, I want to tell you that TIF procedure is a good option. It's one of the options to consider. It's not one size fits all. It's not that everyone should get a TIF, but I think in selected population, it's a very, very good procedure in expert hands. And it's a really good option also when, patients have other diseases such as obesity. You could do it in the same session. And I think that's really something that we'll see more and more. Also for patients who have a poem, achalasia, or patients who've had a Nissen or any surgical fundoplication, you could revise this endoscopically. And like I said, I'll let my surgical colleagues comment on this, but I think it's a really good option for revisions as well. And with that, I thank you again for the invitation. Now we'll open it for questions.
Yeah, fantastic presentation, Roberto. In the chat, there's some questions that I'll just say out loud, but hopefully you can answer those questions there just for the sake of time.
Yep.
Controversies around presence of hiatal hernia and the role for previous anti-reflux surgery. You just discussed that. Greg Morgenthal talked about his experience with LINX and TIF and alternate surgical procedures, which I think is an excellent transition to Dr. Feng. So we're going to, just for the sake of time, have those questions posted to you in the chat. Great talk. Thank you so much, Roberto. And our next speaker is Dr. Chelsea Feng. She's a surgeon in the Department of General Surgery here at Cleveland Clinic. And she's going to be talking on surgical GERD therapies, partial versus total fundoplication, and anything else. Dr. Feng.
Thank you for the opportunity to talk. I feel so intellectually inferior to all the GI, powerhouses here. So I'm, listening with rapt attention. So I'm here to talk about some of the surgical therapies. Let's see if I'm advancing. Okay, here's a quick outline. We'll be talking about some of the indications for surgery, some of the principles that I think are important to reinforce, because, with any kind of surgical or interventional option, including the TIF, those are the things that we're trying to address. Specifically, I'll be addressing the debate between partial and total fundoplication, as well as mentioning about the LINX device. So, the pathogenesis of GERD is complex. There's esophageal factors, gastric factors, duodenal factors, esophageal acid clearance, gastric contents come into play. But I want to call attention to some of the esophageal anatomic anti-reflux barriers, because these are what we're trying to intervene upon when we physically, do an operation on the patient. And specifically, that's the LES, which is a zone of high pressure. And it's a very, dynamic zone, and there are several anatomic features that contribute to it. So obviously there's an intrinsic LES, that distal 3 to 4 centimeters of esophagus that's tonically contracted at rest and will obviously relax with passage of like a food or liquid bolus. That's wrapped up in that phrenoesophageal ligament, which is a continuation of that peritoneal reflection. It's meant to hold that at the level of the hiatus. There's the crural fibers themselves. It's a teardrop shaped organ, and it's obviously very dynamic. And so, physical movements like bending forward, that'll actually provide additional extrinsic squeeze on the LES, theoretically preventing the reflux of gastroesophageal contents. And finally, the acute angle of His, that acute insertion of the esophagus onto the stomach, as well as the intra-abdominal location. So it's subject to intra-abdominal pressure, which is obviously higher than the negative pressure that we find up in the chest. So when we have disruption of these things, the anatomy, that can contribute to GERD. So, what are the indications for surgical referral? I think this question is complex. Sometimes it's a question of when. And the SAGE's guidelines, their direct quote is that adult patients with confirmed chronic or chronic refractory gastroesophageal reflux may benefit from surgical fundoplication over medical management. And they really base this conditional statement on, much research that did find desirable effects of surgery over medical therapy, and that's decreased percent time with abnormal pH, post-intervention PPI use, not that it completely went away, but that it was decreased after surgery over medical, just continuing medical treatment. However, we know that surgery is not free. Many patients, do not want surgery, understandably, because there are adverse GI side effects, and we're going to talk about those. So I think it's a reasonable option to consider in patients with medically refractory GERD. Perhaps they've failed the PCBs that we just spoke about, or sometimes it can also help with people with volume regurgitation. Acid is just one of the things that can bother the esophagus. There's pepsin, there's bile, all these other things that can aspirate up into the esophagus, and PPIs can only neutralize the acid part of that. So surgery may have a role there. So let's talk about actually the surgical options. So we have laparoscopic anti-reflux therapy, specifically total versus partial fundoplication. We have the LINX device, and then I'll just make mention of a Roux-en-Y gastric bypass, and then the endosym, just for completeness sake. I do think my colleague, Dr. Corsellis, may be covering the third bullet in some more detail. So laparoscopic anti-reflux surgery. The whole goal of any kind of surgical intervention here is to correct those anatomic factors that we just talked about at the very beginning. In order to fulfill this, we surgeons obsess over, many aspects of, getting this surgery technically correct, to, give that patient that physiologic function back. So first, the LES must be reduced back into the abdomen. Classically, we always say 3 to 4 centimeters of intra-abdominal esophagus. We want it to be on the right side of that pressure gradient. Of course, we must reconstruct the diaphragmatic hiatus to provide, an appropriate aperture around the esophagus to prevent reherniation of contents. And lastly, the LES must be reinforced somehow to really increase that basal LES pressure again, or inhibit it from, complete, relaxation, which could be contributing to the GERD. And that's primarily done with a fundoplication. So two main types of fundoplication. There's the total, which is called the Nissen, and then there's a couple types of what we call partial wraps or fundoplications. We're going to focus on the toupee because the other ones are more so, they're less done for reflux and more so done in the context of, say, a myotomy for achalasia. So the Nissen fundoplication is a 360-degree wrap. We mobilize the fundus and we wrap it all the way around the esophagus. And we secure stomach, esophagus, stomach to each other, and everything's touching. As a bit of history, Nissen first did this procedure back in 1936 in the context of a perforated esophageal ulcer in a young man. And he actually put that tissue together to bolster that anastomosis, that connection, to protect it for healing purposes. And he made note that the guy had no reflux afterwards. So that is the Nissen. But people found that with the Nissen, while it did give them, good acid reflux control, they did tend to develop gas bloat, dysphagia, flatulence, and inability to belch, inability to vomit. And sometimes these were, especially with the earlier version where the fundoplication used to be 6 centimeters classically, those were in particular very bothersome to patients. So in response to that, the partial fundoplication came about, where we're not wrapping all the way around the esophagus anymore. We're wrapping posteriorly for the toupee, anywhere from 180 to 270. This was meant to decrease the risk of those adverse GI side effects, but some people argue that it gave suboptimal acid relief. I think it bears mentioning that nowadays, these surgeries are done laparoscopically. The patients do well, either total or fundoplications, and mainly our patients stay 1 to 2 days in the hospital. So does that bear out the classic, idea that, a Nissen provides better acid control in exchange almost for adverse GI side effects, and a partial is less acid control, but, less GI side effects. So there's been a great body of literature on this, lots of RCTs, well, not lots, but a decent amount of RCTs and even more observational studies. And here I've just included the results of one meta-analysis, but this is in line with, I would say, the majority of the current literature out there, but people are not necessarily finding a significant difference between total or partial fundoplication when it comes to efficacy in treating GERD. The incidence of esophagitis seems to be the same post-op, incidence of heartburn, as well as persisting acid reflux. What about the side effects? They did find that total fundoplication tends to be associated with higher rates of postoperative dysphagia, as well as flatulence and bloating. So this did tend to be true. However, there are more studies that are coming out more recently looking at very long-term data that suggests that perhaps these adverse GI side effects tend to equalize over time. So I painted somewhat of a grim picture for the total, less reasons to do it per se. So is there really any advantage? I think there are some studies out there that show that there's a possible increased postoperative PPI use after a partial, especially as time goes on. I'm talking about like 15, 20 years out compared to a total. And there are some studies, some strong proponents who argue that, you know, long-term control and nisin still holds favor. I've just screenshotted a recent randomized clinical trial that was published back in 2022, so relatively recently, but this was a double-blind randomized clinical trial, and they just published their 15, 20-year-ish follow-up. They did mention that while in the short term, so both groups had similar acid control, and early term, like less than 5 years, the total group, the nisin group did suffer from slightly more dysphagia. However, over 15 years, they found that the dysphagia in the total fundoplication group did tend to equalize, and quality of life was not necessarily different. So I think the takeaway, I think you should still consider the individual patient. I do not think you can, even based on this data, make a blanket statement. I think Dr. Gabbard mentioned before, one population that comes to mind, the lung transplant patients. Those patients have a vested interest in decreasing acid, and they may, they're probably going to, tolerate a little bit of postoperative dysphagia that equalizes over time in favor of that, more complete or possibly more complete acid control. We also have at our disposal nowadays the magnetic sphincter augmentation device, namely that's the LINX. So these are a series of a string of magnetic beads positioned around the distal esophagus that's meant to increase the tonicity of the LES. And because of their, magnetics, it's supposed to dynamically allow for passage of propagated food and liquid boluses. These are obviously placed surgically. So here you see a picture, the hiatus has been repaired. And importantly, the posterior vagus is dissected free. And so that's outside this grasper that you see here. And then after the beads have been appropriately sized, which is a skill that, has a learning curve, the beads are joined together. And then, this is how it's held in place. There's been a study to compare it to medical treatment, and they did find that over medical treatment, it had better resolution of regurgitation and greater improvement in GERD HQRL scores, fewer total reflux events. However, 32% of the patients reported dysphagia. 7 out of the 15 required intervention, and those were mostly dilations because sometimes you can get a fibrotic reaction from that foreign body being there. They also compared it to laparoscopic fundoplication. They found similar rates of controlling GERD and distal esophageal acid exposure. However, the MSAD group had a better ability to belch and vomit and decreased gas bloat, which is favorable. However, again, they did have a more frequent need for dilation. Also, there's always the concern for device erosion anytime that you're placing a permanent implant somewhere near something so dynamic. They found that the incidence overall is still quite low, 0.31%, and they did find that most of those instances were associated with an earlier version of the device that could perhaps have been smaller beads or inappropriately sized, so basically too small for the esophagus that it was installed on. So just for completeness sake, very quickly before we conclude, the Roux-en-Y gastric bypass, it certainly can be considered a reflux, a procedure to address reflux, especially for patients with a higher BMI and especially for the weight loss aspect, those with obesity-related comorbidities. And then newest on the market is Endostim. This was used in Europe and recently approved by the FDA, is my understanding here. It's an electrical neuromodulator with 2 leads installed onto the distal LES or GE junction, connected to kind of like a pacemaker neuromodulator device implanted in the abdominal wall. So obviously that will require more data. So key takeaways, the LES is a complex anatomic zone. Disruption of these anatomic features can contribute to GERD. we should consider surgery in people with medically refractory GERD after all medical options have been exhausted. Laparoscopic anti-reflux surgery is geared towards addressing these anatomic abnormalities, and there's different options for surgical fundoplication, which we talked about. I don't think there can be a blanket statement made about, Toupet versus Nissen. I do think the individual patient and his or her characteristics should be taken into account. And MSAD is a newer modality for surgically addressing GERD, but obviously more long-term follow-up is needed.
Excellent presentation, Chelsea. I think you captured the spectrum of surgical therapies that exist. For the sake of time, we'll put questions into the chat. It seems to be there's some ongoing conversation about strata. So maybe Dr. Simmons-Linares, Dr. Chin, and Dr. Gabbard can chime in on that. And then it'd be fascinating to see how this partial versus total fundoplication conversation plays out. Our next speaker is Dr. Ricard Corsellis, who's a staff surgeon in the Department of General Surgery. And he is going to be speaking on special considerations, which now Dr. Feng just alluded to. And he's going to specifically talk about obesity epidemic and GERD therapies. Ricard.
Thanks, Matt. So far, very great event. I've been learning a lot. So for sake of time, those are my disclosures, and this is the outline of my presentation. So we are really dealing with a very, very important problem here in the US. 40% of our population lives with obesity and 10% severe obesity. This is actual data, but the projection in 2030 is doom. Almost 50% of the population will suffer from obesity and 25% of severe obesity. And if you can just take a look at that, this is a snapshot of the prevalence of obesity among US adults. And you can see that, let me see if I can just pass this. So 19 states in the US have a prevalence of 35%, and almost 40% of obesity. 3 states close to ours, which are Louisiana, Oklahoma, and West Virginia, the prevalence is 40% or even more than that. In Ohio, our prevalence is 40%, and we all know that there are racial disparities. Can explain that too. But what concerns us today is GERD, and especially the association in between GERD and obesity. It has been widely demonstrated that obesity is an independent risk factor for GERD, and it's been estimated that the odds ratio is 1.7, which means that almost the risk of having GERD in somebody that has obesity is doubled. And the prevalence of GERD, it is described, it can be up to 70%. This is the pathophysiology that has been associated with this elevated prevalence and incidence of GERD in patients with obesity, and increasing the transdiaphragmatic pressure, defective LES, hyposalivation that sometimes happens in this subset of patients, which translates, worse esophageal clearance. We all know about the association of dysmotility and an abnormal gastric empty in patients with obesity. The increase in abdominal pressure also is a risk factor for a hiatal hernia in these patients that is also, of course, associated with GERD. So the impact of obesity on GERD is dramatic, and those are the potential complications that are known by everybody. I'm not going to spend that much time here. Regarding the preoperative testing, I think that Dr. Gabbard and my colleagues have already discussed about. Those are the options, the tools that we use to diagnose GERD in that population, as well as the therapeutic strategies, not including bariatric surgery that my partner, Dr. Feng, already discussed, which I'm not going to be talking about at this time. But when you evaluate outcomes of laparoscopic anti-reflux surgery in patients with obesity, we find that those outcomes are not optimal. Now, this is a meta-analysis conducted by 2 institutions in the United Kingdom, and these systematic review and meta-analysis, including hundreds of patients, and including one of the 6 most large papers in the literature. All the studies favors that a patient with a BMI less than 30 is associated with less GERD recurrence. It is also estimated that the rate of recurrence can be close to even 40% after conventional laparoscopic anti-reflux surgery. So here is my point, that bariatric surgery, especially the gastric bypass, is a phenomenal anti-reflux operation in patients that have obesity. The reason why is depicted in my slide. Is a parietal cell separating procedure. We eliminate completely the reflux, the duodenal gastric reflux, by building and constructing a long limb. We favor that this is a clear anti-reflux operation, and of course, with weight loss and the decrease in intra-abdominal pressure, we know that that's another robust effect of the gastric bypass. If we look at large data, I want to point out that study in short. This is a study that was a review of the bariatric outcomes longitudinal database. The study is including over 20,000 patients that had reflux requiring medications who were undergoing bariatric surgery without hiatal hernia repair. So the main outcome was to report resolution of GERD at a minimum of 6 months follow-up. The authors encountered that, not surprisingly, the Roux-en-Y with 56% of cases was improving reflux. On the second place, we had the gastric band of 46, and the gastric sleeve was less effective with reducing acid reflux in patients with obesity. And a positive predictive factor, of course, of GERD resolution was weight loss. However, there's been conflicting data about the novel GERD in patients that had undergone bariatric surgery. So we have to acknowledge that and recognize that there is an incidence of de novo GERD. However, the data is not really robust. We know that most of the studies are retrospective with a limited follow-up time. It is described that about 10 to 30% of patients after sleeve gastrectomy can develop reflux. And then emphasizing on that, I want to show you that study published in Surgery, where the endpoint was to evaluate the effect of sleeve gastrectomy on GERD. Among these almost 12 studies, the authors only found that 2 of them were showing positive outcomes in terms of improving reflux post sleeve. The majority of them were showing that sleeve might create a new onset of GERD in our patients. So those 2 studies for our group, led by Dr. Crow. The first study, we reported the experience at the Cleveland Clinic of conversions on patients who had a sleeve gastrectomy, and then we converted to a gastric bypass. Those patients, among all these patients, 40%, the reason was an untractable reflux. And then this second study, which was published showing our experience at the Cleveland Clinic Abu Dhabi, we can see that GERD was the reason for conversion in 60% of our patients. So GERD post sleeve gastrectomy is a real situation and a real problem. I don't know, Matt, if I have time to show a couple of videos. If I can, I will go ahead. If not, I'll go through my take-home messages.
You can show what your best video here. Give us like 30 seconds of it.
Okay, so this is the dissection. For those who are not surgeons, here is we're doing the dissection of the pouch that was a prior sleeve, and we were basically dissecting and creating a small pouch. You can see how when you are revising a sleeve, you can just basically build your pouch with make it like a rectangular pouch with two staplers, and you divide the pouch. You can see how this is under well control and how MIS and robotic surgery can allow us to do that. I think that I have a second video here. Just let me show, this is the pouch that we built, and we brought up this loop of bowel, and we will be creating the gastroesophageal anastomosis. And by this Roux-en-Y reconstruction that you can see here, we're going to be the Roux-en-Y reconstruction. We're creating this anti-reflux procedure that will be solving reflux in these patients that did have priorly a sleeve gastrectomy. This is the jejunostomy, and with that we conclude our operation. So in conclusion, I will say that obviously obesity increases the prevalence and the severity of GERD and hiatal hernia. In general, bariatric surgery is an excellent tool to treat patients with GERD. Bariatric operations are at least equally safe than any other anti-reflux procedure. The Roux-en-Y gastric bypass is by far the ideal operation to treat patients with obesity and GERD. And we need to acknowledge that a subset of patients, about 30%, can develop GERD after sleeve gastrectomy. And with that, I'm concluding. Thanks so much again for letting me present here. Thanks.
Rickard, fantastic presentation. I am immensely grateful to Dr. Gabbard, Chin, Simmons, Linares, Fang, and Corsellis. I, of course, am totally biased, and I said this at the beginning. This is an outstanding topic, but what a world-class group of academicians and lecturers we have here. For those of you who are interested, our next two live events from Cleveland Clinic program will be the difficult stoma on November 13th and emerging trends in gastroenterology on December 11th. On behalf of my co-activity director, Dr. Matt Walsh, and our esteemed faculty, thank you all for joining, and have a wonderful night, afternoon, or morning, wherever you may be joining us from. Take care, everyone.